Hi there, Mark Whiteley from Guildford in the UK. I'm going to have a quick chat to you today about using HIFU for incompetent perforating veins, but some of my colleagues are also going to talk about that. So I'm going to do less about the HIFU side and more about why you should or should not treat incompetent perforating veins, because it's been a massive you'll see from some of the speakers today, some people will treat perforators, some people won't treat perforators, and as most of you will know, in the literature there's been an awful lot of controversy over the last about 30 or 40 years, really. So there are these sort of papers that say you don't need to treat incompetent perforators, because if you treat truncal veins, they will just disappear. However, other research has shown that's just really quite, people just want to believe that because they think that if they don't have to treat perforators, then it's going to be easier, because before HIFU came along, you had to learn either SEPs or you did big incisions for perforators, like the Cockett procedure or the Linton procedure. And so people, rather than learn how to do it easily, actually tried to get away from it by saying you don't need to do it. So when the original trials were sort of done and people looked, did the perforators still appear? Were they still incompetent at 4 weeks and 6 weeks? Of course they weren't, because you'd been wearing compression, you'd had your major veins treated. And so what would happen is you'd have thrombosis, and it looked like the perforators weren't a problem. However, when we did a study in 2004, we merely found that all that happens is the thrombosis resolves and the incompetent perforators come back. And there was part of this transatlantic debate, I was trying to explain it, and the debate was published both in America and the UK at the same time. And it's brought a lot of people on board with understanding that incompetent perforators are important in treating with C2 disease and sometimes even C1 disease, although most people still only look at it in C6 disease. So this is some of the research showing that recurrent varicose veins are one of the major causes of recurrent varicose veins are untreated incompetent perforators, and this is why you should concentrate on incompetent perforators in our view. There's some unpublished data that we're just about to put into one of the big journals, just showing purely and simply that on presentation, the presentation of any patient is worse using the CAP clinical scoring. And I know that's not a grading system for severity, but it does give you a snapshot of how severe the person is when they turn up. And the more incompetent perforators you have, along with your truncal reflux, the worse your grading when you turn up. And when you're looking at 22,000 legs, that actually becomes very significant, because it actually shows there's a very, very good correlation. And this is an association or causation that may be. But one of the things we did look at, we then looked at about 900 odd patients who had only incompetent perforators. And we found that if you have 2 or 3 below-knee incompetent perforators, you have the same level of inflammation at your ankles and the same clinical presentation as if you have an incompetent truncal vein. So this is quite strong evidence to show, along with the other things that we've been publishing about the inflammatory changes around these, that in fact incompetent perforator veins should be regarded as importantly as truncal veins, although you may need 2 or 3 to get the same damage as one incompetent truncal vein because of the volume effects. So in this room, there are at least 2 different sorts of ways of treating veins. And although we have a very good device for treating veins, your approach is going to vary depending which you believe. And it's whether you believe in ablation, which HIFU does very well, or hemodynamic surgery, which HIFU also does very well. So you can use the same device and you can have different approaches. What I found is those people who understand the hemodynamic approach tend to know about the ablation as well. But people who do ablation, certainly in the Northern Hemisphere, have never heard of the hemodynamic approach. And certainly in England and a lot of Nordic countries and a lot of states, there's a lot of misinformation. They haven't ever even heard about hemodynamic surgery. So our view is that you get reflux from your great venous vein by passive reflux, and you also get active reflux or systolic reflux coming out through your perforators. So our treatment would be, using HIFU, we would ablate the great venous vein and the incompetent perforators. If you look at Shiva more classically, you regard the perforators as always being your friends, and you regard the fact that there will always be a inward flow from a perforator regardless of what the valves are doing in it, and therefore you'll do this sort of Shiva type operation where you'll stop the reflux but leave the incompetent veins to drain through a perforator. And of course, ASVAL, which is sort of a bit of a sort of a side talk, really. It's just you just remove the venous reservoir. So we know even from Paul Pitaluga's work that it only affects about 5% of people. So it's not really a strategy. It's just useful for people with early varicose veins. So it really comes down to Shiva versus ablation. And it's not for this forum to discuss one or the other. But if you believe in the ablation, then certainly you need to treat perforators. And there's been a lot of our areas of research because there's been principles from Claude Franceschi and Zamboni who suggest that perforators will always have an inward flow because of the change of the Venturi effect. So they'll say you have a faster flow up your deep veins, and by the Venturi effect, that will actually suck blood in through the perforators. But our view is that pales into insignificance with the immense pressures that are subjected on the deep veins by the contraction of the muscle in the first place. And in fact, there's no evidence that you do get much of an increase in flow up the deep veins in any case. So to look at that, we looked at one small incompetent perforator. This is, I believe, on a preprint server at the moment, and it hasn't been published yet. It's under peer review at the moment. If you stand up and you use the near-infrared spectroscopy, which we presented yesterday in the e-poster presentation, you can actually see the blood coming out through that perforator passively when you stand up. Now, just to explain this, normal blood is cold if it's venous under the skin, goes into the muscle, gets hot, and goes back to your heart. So if your valves aren't working and that hot blood that's already in the muscle comes out, you can see that as a signal by it going hot, and that's the redness, the yellow there. So normal blood, normal venous blood, you can't see on infrared. You can only see it when it's been heated because it's in the deep system and it refluxes out. So that you can see there is passive reflux in this baloney perforator. But very interestingly, what we were trying to show is that if you're lying down and you've got absolutely no gravity at all, does active reflux play a role at all? And as you can see from this video that's going on, as this patient is lying flat, you can see slowly she's pumping blood out through the incompetent perforator, which is the only venous pathology she has in her leg. We now have a series of these patients who have turned up with symptomatic varicose veins or cosmetic varicose veins, ones they don't like. There's from a single perforator, and we've done the same technique on each of them. And it's one of the things we're now looking at to protocolize to work out which perforators do need treatment and which ones don't. Because obviously there is no dilation of this perforator from reflux elsewhere because it's the only incompetence in the leg. Also, of course, those of you who treat Klippel-Trenaunay syndrome, we know it's a range of genetic syndromes. The phenotype is all called Klippel-Trenaunay, but the genotype is now very widespread. There's many different sorts. But it's basically, as I've been presenting recently, it's basically a perforator vein problem. And in the past, people used to talk about all the different problems you have with Klippel-Trenaunay being a syndrome of the lateral marginal vein, etc. But if you actually look at it, the diagnostic criteria for Klippel-Trenaunay really on ultrasound is that you have an inordinate number of incompetent perforators. And this is an absolutely ideal sort of patient you could treat with HIFU. So the principles there, as I said, are to treat the perforators. So this is the sort of thing we'll see with the Sonovein machine. We'll see the perforator. You can see with the magnification, it's absolutely beautiful to see it coming straight through the fascia there, the deep fascia. The level at most areas of the leg is more or less within the range that you want it to be in. If it's not, there's some techniques I'll describe very briefly in a minute. This is a before and after of the immediate treatment of a perforator. You don't treat it with one zap, you actually use several. I've sort of relinquished some of my actual treatments now to our very good vascular technologist who's recently presenting her work showing that her results are better than mine, so I have to bow to her sort of experience. And I also have to thank Thoracium for lending us their clinical specialists who have actually been guiding her and me as well. But with the perforators, what we find is I personally love the new 0.5 seconds. And I will quite happily do 20 or 30 shots for 0.5 seconds. And just if they start feeling a little bit of pain, I'll stop, let it cool down, and just carry on. And you get fantastic results. If you want to be a bit faster, you can use the 4-second pulse, and there's nothing wrong with that. It's just the thermal spread is a bit more, and therefore you have to be a bit more liberal with the local anesthetic. So it's sort of horses for courses. As long as you get enough energy into the vein wall, you'll get ablation. It's just the whole thing for me about perforators is trying to restrict the thermal spread. This is some work that was done by my colleague Barry Price, which is, if you want to see it, it's on the preprint server, and there's a DOI there. Again, we haven't had it accepted for publication yet, but this is from his 14,000 patients with perforators. And any of you who talk about Cox perforators or try to give them names, they don't exist. There's no such thing as a named perforator, because they're just a cloud of perforators in a certain area. And this is what you can see here. The tibia is at the middle, and these are where we're superimposed the locations of perforators in 14,000 people. And you can see there's a lot of them that are out in the meat of the calf, but many of them are up by the side of the bone. And this becomes important when you're aiming your HIFU. What you want to do is position your patient, and you don't just think about the cone of power, which everybody's talking about here, going into the perforator. Just remember also the energy coming away from it as well, the other side. So try and make sure you're skirting the bone and not actually going towards the bone if you're treating it. So it's all about positioning of the patient and and just thinking where the energy lines are going. Also, if you're low in the leg, it's quite hard to get the distance, and so this is the one place where we use tumescence, and to keep the local anaesthetic low, I'll use just normal saline to actually pump the skin away from the perforator, just to make sure I've got enough safety from the skin to the perforator to do. So there's many tricks you can actually do. Thigh perforator is very, very nice with HIFU because it's the right depth, right place, and we all know about the mid-thigh perforators as a major cause of recurrence, and so this is a very, very nice technique to use for that. And in the popliteal fossa, it's the one area we're very cautious with HIFU at the moment because of the risk of foot drop. And we all know that the perforator of the popliteal fossa is a very difficult vein to do. So it's one of those areas that you have to be cautious with, but you also have to be very cautious with endovenous thermal ablation as well in these veins, because they are very, very unforgiving. So as a sort of wrap-up of everything, I'd say that for perforators, it's the place you have to always use local anaesthetic because half the perforator is associated with muscle. So there are some patients who can cope with it with the 0.5, but if you're going to use the 4-second pulse or longer, you will need local anaesthetic. Some people with a bit of nefapam and talking to actually don't need it if you just keep zapping it with the little 0.5-second pulse. It is so quick and easy, and if you're running a clinic, one of the nice things about it is these patients are coming in, and say you've got 3 perforators to do, or even 3 perforators and a bit of great venous vein, you're an awful lot quicker doing that if you count all the time of getting the patient into theatre, scrubbing them up, getting them all gowned up, then doing the procedure, then mopping up any blood, taking all the instruments off and putting them back. If you look at the business case, rather than maybe your time in theatre, it's actually, without doubt, one of the quickest wins in venous surgery. And so for us, if we've got people who have just up to about 10 perforators, we think there's a significant advantage of HIFU over doing any sort of endovenous technique. Thank you very much.